Hey doctors, have a good day. Today we'll be discussing the abdominal station of the PACES exam. This session will cover the key examination techniques, common findings, and clinical scenarios you may encounter. Some of the common scenarios which we can encounter are the chronic liver disease, hepatomegaly, splenomegaly, ascites, transplanted kidney, polycystic kidney disease, hemochromatosis, primary biliary cirrhosis, or primary sclerosing cholangitis. So when you enter the room, you have to smile, greet, and introduce yourself to the patient. And also you have to tell the patient that why you are here, what's your purpose. So you must observe the surroundings, look for related objects, medicines. You can go and check the medicines, by the way. Any connected devices like cannula, any Foley's catheter, any other thing, any other device, any oxygen mask, any oxygen cylinder. So observe the patient, ask him to cough, and focus on the abdomen for any hernia, any scar marks, any abnormal mass, any other visible sign which you can see. Okay, then you move to the hands. So either you can shake hands and observe, or if you're not comfortable, you can just skip the shaking and just observe the hands. Ask the patient to extend the hands and look for any signs of clubbing, any pallor, euthanasia, koilonychia, any pinprick signs on the palp of fingers, which may be suggestive of diabetes, recurrent contractures, which is suggestive of alcohol-related diseases, palmar erythema, which is indicative of a vasodilated state of cirrhosis, pregnancy, etc. Flapping tremors. So anemia can be suggestive of a blood loss due to esophageal varices, bone marrow suppression, any drugs you are taking, any alcohol, increased uptake, poor nutrition, all this. Palmar erythema is indicative of hypercapnia, pregnancy, and rheumatoid arthritis, thyrotoxicosis, fever, exercise, etc. So you have to observe carefully for all these signs. So after the hands, you go to the arms and to the neck. So you look carefully for any fistula and identify if it's active or not, because the examiner will ask you if it's active or not. So the active ones have a blowing sound heard with the needle prick marks over it. So you have to put your stethoscope over the bulged mass and look for any blowing sound. Okay, and you have to see if you see that there are needle prick marks over it, it is an active fistula. Also look for any petechiae and ecchymotic changes, which is suggestive of a coagulopathy or thrombocytopenia. Look for spider look for any other signs which is suggestive of any liver disease or anything you can see, like tattoos. Tattoos are suggestive, or it can be a clue to an underlying pathology like any viral or acute hepatitis. Okay. Also, when we reach the neck, look for any central line in situ, or there are scars suggesting that previously there was a central line. Look for scratch marks or any scars. So after that, you move to the face and neck and you start your observation. Okay. So overall, look for an overall appearance. If the patient has a Cushing-wide appearance, which may suggest of a steroid use. Look for any pallor or icterus. Look for in the eyes. Ask the patient to pull the eyelid, one or both, and look for any pallor or icterus. Look for any cave rings, which may be suggestive of Wilson's disease, which may further give you a clue that this is the case of CLD, and the primary cause was Wilson's disease. Look for gum hypertrophy, which indicates that the patient is on immunosuppression therapy, which may also give you a clue that the patient probably have an organ transplant, which is requiring him this immunosuppression. Also look for parotid swelling, hearing aids, any flushing of the cheeks or redness around the face. And then you look for any cervical lymphadenopathy, which may give you a clue if they are larger than the normal. It may give you a clue that it might be associated with a malignancy or a leukemia or lymphoma. Look for JVP. Remember that JVP has always should be checked when the patient is at 45 degrees and never at 90 degrees. So you have to be very careful regarding this, and look for any scars. You cannot miss the scars, okay, in the basic exam, because the examiners may not forgive you for that. So after examining the face and the neck, you move to the chest and look for signs like spinal nevi, scratch marks, any loss of body hair, any gynecomastia or CLD. It's suggestive. All these signs are suggestive of CLD. Gynecomastia, they may ask what's the reason of gynecomastia. So you can tell that it is due to altered sex hormone metabolism. Look for tattoos. Tattoos may again indicate of an underlying liver pathology. Look for dilated veins, which may suggest a diagnosis of portal hypertension. So these are a few of the signs. After examining the chest, you move to the abdomen, and you start with inspection. Look for scars. Look for transplant. It may be a kidney transplant scar, it may be a liver transplant scar, it may be a J shape, it may be a combined transplant scar. So you have to look for them. Look for any scars for peritoneal dialysis, any devices that the patient might have still, any distension of the abdomen, which may give you a clue that it might be ascites, everted umbilicus, spinal nevi, dilated veins. So you have to do this inspection carefully and look for these signs. After doing the inspection, you start with the palpation. Palpation has to be superficial and deep. Superficial is the basic purpose is to identify if the patient has any tenderness around, and if there is any tenderness on the superficial, you will avoid that area in your deeper palpation. So in the deeper palpation, look for any organomegaly, especially you cannot miss liver, spleen, kidney and aorta. Okay, even if it's not present, you have to show your technique to the examiner. Next is percussion. You percuss for the organs and you assess the ascites. Then there is auscultation. You look for any bruise. Now the causes of CLD. As we mentioned that the most common cause in our abdomen station is CLD. So we have to, in 3 minutes, the examiner can only ask you what the causes, investigation, and the management. So you have to be very careful about these causes. Some of the causes of chronic liver disease are alcohol, viral, immune, autoimmune, metabolic, and drugs. In the signs of alcohol or chronic alcohol abuse can be uterine contractures, parotid swelling, cachexia, tremors, peripheral neuropathy, and cerebral syndrome. For the viral causes, probably most commonly hepatitis B and C, usually is suggested by the IV drug abuse signs like there are tram-track appearances on the forearms, there's purpura, there's livido reticularis. So all these signs will point towards an IV drug abuse. Also, in the autoimmune causes, we can mention primary biliary cirrhosis, sclerosing cholangitis, autoimmune hepatitis. It can be suggested by scratch marks, xanthelasmas, hyperpigmentation, etc. In the metabolic causes, if you notice that the patient is obese, you can think about non-alcoholic steatohepatitis. If it's there are signs which are suggestive of hyperpigmentation, diabetes, joint pain, hyperpigmentation, it can give you a clue towards the hemochromatosis. Wilson's disease can be suggested by Kerfring's, akinetic Ridge syndrome. You can look for alpha-1 antitrypsin deficiency. They can be cause of cystic fibrosis. They are cause of drugs. For example, if you notice there's a medication lying around the patient's bedside, you may think that it may be related to a bedside. For example, it's a medicine methotrexate. You can think that it might be cause of the chronic liver disease. Now, there are some of the complications of a liver cirrhosis like portal hypertension, hepatic failure, ascites, SBP, jaundice, hepatorenal syndrome, hepatocellular carcinoma. So all these complications you must be able to list if the patient asks you what are the complications of a liver cirrhosis. Now, for example, if the examiner asks you for the investigations of this case, so at this point of time, you don't know, but you can give him a differential diagnosis. So how will you answer this question? You'll simply say that, doctor, if that the reason is alcohol, we need to take a proper history from the patient, detailed history. Also, the cause can be viral hepatitis. So rule it out. We need to do a hepatitis serology, including the hepatitis B and C viruses. If the cause is towards metabolic syndrome, like hemochromatosis, we need to do serum ferritin, transferrin, TIBC, serum iron levels, HFE gene. If it can be also a Wilson's disease, if you notice any KF rings, and you can answer that we need to do a serum copper levels, urinary copper levels, ceruloplasmin, etc., etc. In the case of autoimmune disease, you need to mention that we need to do the antibody tests and henceforth. So, and if, for example, you suspect drugs are the reason, you have to again include that we need to take a detailed drug history for the patient and to identify. So at this point of time, you'll only give the differential diagnosis. You cannot tell just on the examination that what is the exact cause. So you have to give a detail, in your investigation plan and your management plan as accordingly. One of the most common management plan they'll ask you is for ascites. So you have to mention therapeutic parasynthesis followed by diet restriction, salt restrictions, spironolactone, furosemide, fluid restriction, and liver transplantation. Everything fails. They can also ask you that if you do everything else, and still the ascites is not responding to it, how will you manage it? So you must know that tips or large volume parasynthesis are other options in the cases of refractory ascites. Another complication can be acute variceal bleeding, and you may have signs of that in your patient. So the examiner, he may ask you that how do you manage a case of acute variceal bleeding. So you may say that first we'll try a drug therapy, and my first choice will be terlipressin. My second choice will be somatostatin or octreotide. If still it's not responding to that, we can go for invasive procedures like endoscopy followed by band ligation or sclerotherapy. Now he may ask you, okay, what if it isn't controlled by that? Then you can answer that we can go for a repeat endoscopy, or if not, then we can do a rescue tips or a shunt surgery.